Good afternoon. First of all, I would like to thank Dr. Naman for this kind invitation and all his surgical team, and also the Tamam Hospital for this great organization. So today we'll discuss about total hip arthroplasty, especially with direct anterior approach. I have no conflict of interest for this presentation. So in France, we perform around 150,000 total hip arthroplasty each year. Usually we use a posterior lateral approach, and this picture is the city of Lyon, nice city where I did all my medical study in the Croix Hospital with Professor Neret and Lustig and Servi. Now I'm working in a private hospital in the French Alps, very close from Geneva and close from Chamonix also. It's a nice place where patients perform lots of sports. And first of all, I would like to say what are the patient expectations in total hip arthroplasty. Naturally, patients want a painless hip, and for the older war, self-sufficiency. They want rapid recovery to sports, but also to work. They want stable hip, same length, and maximum lifetime. What are today the surgeon expectations in total hip arthroplasty? Naturally, first of all, we want a perfect stability, no idea about dislocation. We want to be sure about the lower limbs length with no inequality. If possible, a controlled X-ray performed during the surgery, making sure it's good size, there is no fracture, it's security for the patient and the surgeon. Fast rehabilitation is very important, it's less time at hospital. We want a security surgical approach with no nerve or vascular injury, and naturally a technical replicability, easy to teach, easy to perform. For infection, the lowest number is the best. So at the end, we want an easy, quick replicability surgery, no complication after the surgery, and for the patient, quick recovery, a forgotten hip, no pain, and for the longer time. Surgeon will have the responsibility of the patient. First of all, for the indication, making sure it's a good indication, then preparation of the surgery, planification, naturally, offset and length. The surgeon will also decide about his surgical approach and the choice of his implant. What kind of friction torque, cement, cementless. This responsibility will incur before, during, and also after the surgery for many years. So, why choosing direct anterior approach mini-invasive surgery without orthopedic table? The main advantage is that naturally it's a mini-invasive surgery, so fast rehabilitation after. It will allow the surgeon to control the length of the lower limbs during all the procedure. Will be sure to have a very good hip stability, fast recovery. You won't need to buy an expensive table, and the surgery is done on dorsal decubitus, so it's easy for the installation and also easy for the anesthesiologist. What are the inconveniences? As usual, when you change your surgery approach, you will have a learning curve. People say it's difficult. I would say after 30 cases, it's quite easy to perform this surgery. In case of revision, this direct anterior approach could be difficult, and also in difficult case as obesity patients. So I won't describe all the different surgical approach in total hip arthroplasty. You can see on the right, this surgery approach will be done between the tensor of fascia lata and the rectus femoris. Indication for this procedure, usually indication. Hip osteoarthritis, naturally, in my hands it's about 90% of the case, but you can also perform this approach for femoral neck fracture, osteonecrosis, that is a really good indication, and usually young people or other case. The pre-operative preparation that is done in our hospital is naturally pre-operative physiotherapies, making sure the patient will be able to walk easily with crutches after the surgery. medical optimization with the anesthesiologist team, and we always take care to correct anemia and to have a good diabetes control in order to provide post-operative infection. House return, making sure physiotherapist and nurse will be there, patient information and sepsis prevention, teeth care and everything. What kind of implant do I use? This is, I think, one of the French paradox. In 95% of the case, I use dual mobility, as you can see on the right picture, with cementless stems and cotyle. But with this approach, you will be able to use ceramic, short stem, cement, no specific implants are needed, and it's not short stems. As I told you, no orthopedic table, standard table, and the only specific instrumentation that you will need is on this picture. So just some surgical spacer, orthostatic, and some retractors are needed for this technique. I won't discuss a long time about pre-operative planification because we'll have a discussion after. I have two possibilities: using the computer system with the XNOV procedure. It's easy to do. You just need to import a 28 millimeters sizings X-ray on your computer, or the classical on papers X-ray that you can see on your left. So in this approach, there is no muscle or ligament injury, and also no hip dislocation. This will allow us to perform what we call in France RAC, that means rapid recovery after the surgery. It's very important for the patient to be not painful after the surgery, to spend less time at hospital, and return to job or sport in a couple of weeks. It also decreases cost, and after the COVID crisis, it's important. What kind of anesthesia I recommend for this surgery? General anesthesia is my recommendation because the muscle release during the surgery is very important. So we use curare during the surgery if needed. You can also use spine anesthesia, but in this case you have to make sure you have a really good muscle release. Otherwise you can damage the muscle, and it's bleeding a little bit more, and the patient could be more painful after the surgery. At the total end of the surgery, I use local anesthesia, usually 60 square centimeters of ropivacaine, just to make anesthesia around the scalp and in the muscle. In post-operative, we will just use some anti-inflammatory and usual painkiller. It's not a painful procedure. So this is a picture just to show you the organization in my hospital. So this is just a couple minutes before the surgery. On the right, you can see the planification. Nurse are making ready the table, and the anesthesiologist, it's very easy for him to perform a general anesthesia. Patient is installed on dorsal decubitus. Just before to make the anti-aseptic, I always take care to draw my future scare, and I make a point on the upper anterior iliac spine and the great trochanter, and you can see that the incision will be done in the middle. You can also perform a bikini scare, but my friend will speak about that in a couple minutes. So this is the organization during the surgery. You can see the nurse with her two tables. I'm on the right, and my operative assistant in front of me. Same pictures in another way. So now I would like to show you and describe our last movie, because at its mini-invasive surgery, it's not always easy to see for the surgical assistant, and we try to make this movie, and I hope you will see all the important times. So just a couple minutes before the surgery, my planification, making sure offset and lower limb length will be okay, even if we'll control this during the whole procedure. This is just to show you the computer planification. It's also really easy to do with the map scale X9 solution. So with these 28 millimeters balls, you will be sure to have a very precise planification. You can move the stems in all rotation, all the size, and it gives exactly the same results on paper. I use both, usually on difficult case, computers, planification, making sure I will have all my implants. And if it's standard total hip arthroplasty, just paper planification, couple minutes before the procedure. So this is skin marks, and we'll perform the anti-aseptic preparation. And what is very important in this technique is to making sure you will have both legs in the sterile drapes, because we'll have to perform some different position. You have some special drapes made for this surgery, but it's a little bit expensive and we don't have it on my hospital, so I use standard one and it's working very well. So this is the skin incision and making the dissection of the soft tissue under the skin. And the first time will be to find the tensor of fascia lata aponeurosis. So I take care not to open it at this time, and slowly making sure I will find the good plan, and you will have this, it's easy to find, red aponeurosis that I will open with the cold blade. We take care not to damage the muscle, and at this time we'll perform a digital dissection, making sure not having any damage of these muscular fibers. I use this orthostatic surgical spacer during the whole procedure. And you can see, I can see and feel already the femoral neck. And I will describe you now my extra-articular time. So I will put the first retractor on the upper part of the femoral neck. Then the second time is to put another retractor on the femoral head that we develop, and it's easy to put. And the last one on the under part of the femoral neck. So this is the extra-articular time, and we can easily find the surgical landmarks. And now I will proceed. I will open the capsule. You can, if you want, just open the capsule, but I always remove the anterior capsule because some patients can have stiffness, inflection of the hips after a couple of weeks. So I remove the whole anterior capsule, as you can see, making sure I can visualize the great trochanter, and I will have all the landmarks to perform my femoral neck cutting. You can cut in one time, that's what I'm doing on the video, and when you start, sometimes it's easier to perform two parallel cuts and to remove, first of all, a part of the femoral neck. So now you can see I will remove the femoral head, so no dislocation, as I told you. And the femoral neck is removed really easily. You can see now the cotyle, and I can start with just an anterior retractor, the preparation of my cotyle. And as I told you, you will be able to use dual mobility or ceramic implant as you want, as you wish. I do a cotyle test, making sure I will have a good press fit. And at this time, you can also perform a control X-ray if you want, that I don't do anymore. But as you can see right now, I'm making sure there is good bone in the anterior part, making sure I won't have a psoas syndrome after the surgery. So this is the definitive dual mobility cotyle with a good press fit. And now I will start my femoral time. So this is the difficult time, making sure we'll have a good exposure of the femur to make a good femur preparation. So I will liberate the anterior capsule of the great trochanter, and the left retractor is a femoral retractor, and the important time of this surgery is to make this position that we call number 4 position. Now you can see upper view of the femur that I will catheterize, and with this special rape, making sure I'm in the good axis of the femur. And this is very important to be sure of that, otherwise you can have bone fracture. Then, time by time, I will put the femoral rape, number 9, number 10, etc., until I have the one I planified on my X-ray. At this time, I'm making sure I have good press fit also, and no loosening in rotational movement. So I use a collarette on my implant, that's why I have this special rape. And now I will perform the test. Two kinds of tests. First of all, I will check the lower limb length, naturally, as you can see right now, and X-ray control, making sure the size is good. It takes a couple seconds, but for me it's a good security. And also test my hip stability, making sure in all the movements that are very, very stable. I just need to remove the different rape, and now I will put the definitive femoral stem. I use a plastic to protect the skin, and as you can see, it's really easy to introduce, and for the last centimeters, making sure I have good press fit. We will use a double mobility torque, so the stem is in the good place. This is my dual mobility with a ceramic head, and I will proceed to the hip prediction, so extension and external rotation. I control again the lower limb length, a last control X-ray, making sure everything is okay, and the surgery is finished. I will just need to close the fascia lata as we perform it usually, and to put some local anesthesia, making sure the patient won't be painful couple hours after the surgery. So the advantage for me is that I will be able to control lower limb lengths before the surgery, during the surgery. I will be able to test my stability during the surgery and having a control X-ray. And you can use different kind of implant as you wish. Immediate post-operative, it's very important for us to have precose lift and walk, so with crutches. Some patients are able to let the crutches in the bedroom after 1 day or 2. I don't always put a rodent drain, except if it's bleeding, and in this case, it's always removed 24 hours after the surgery. No intravenous drug, precoce rehabilitation, and I use this game ready for ice on the hip. This is our result with my associate, Dr. Lénard. We are now over 1,000 procedures since 2017. We didn't have any patient for dislocation, total hip arthroplasty. We did have 2 infection, quick infection after surgery, 15 days after, and in both cases I performed an anterior approach for revision, and I changed all the implants in one time with the same scare, and patients are doing well, and both are considered as cured. We did have 2 periprosthetic fractures, and in these 2 cases we had to perform a posterior femoral revision because the fracture was going very down on the femur. no revision for limbs length inequality, and no revision for loosening, and we hope to publish this result in the next 2 years. I thank you again for this kind invitation to Vietnam, and I hope I will have the pleasure to welcome you in our next Congress in Lyon. This year it will be on the patella, and thank you very much.